The House Appropriations Subcommittee on Health and Human Services will come to order. Clerk, please take the roll.
Chair Morse.
Here.
Vice Chair Martis.
Here.
Representative Hood.
Present.
Representative Braybick.
Here.
Representative O'Neill. Representative Hurry.
Here.
Representative Farhat.
Here.
Representative Price. Representative Skaggs.
Here.
Representative Snyder.
Here.
Vice Chair Green.
Present.
Representative Bolin.
Here.
Representative Meerman. Representative Kuhn.
Here.
Representative Steele.
Here.
Madam Chair, you have a quorum.
Thank you, Clerk. The committee will go at ease.
Representative Hood makes a motion. We call the meeting back to order. Freshman mistake, obviously. Representative Hood makes a motion to approve the February 14th, 2024 minutes. Hearing no objection, the minutes are approved. Today we have a number of presentations from folks primarily focused on maternal infant health. First, if we could call forward Dawn Shanafelt, who is the Director of the Maternal and Infant Health Division and Title V Maternal Health, and Amy Epke, Senior Deputy Director of Financial Operations and Administration. They are both from the Department of Health and Human Services, and with that, the floor is both of yours.
Good morning, and thank you for the opportunity to be here again today. My name, as mentioned, is Amy Epke, and I'm Senior Deputy Director of Financial Operations with DHHS. I'm joined today by Dawn. As mentioned, we're going to talk a little bit about the maternal and infant health services within the department and the proposal before you. As you heard Director Hertel indicate last week, all Michigan moms, babies, and families should have access to appropriate quality and timely care, as well as access to resources to help them thrive. The department appreciates the legislature and governor's support for the Healthy Moms, Healthy Babies funding initiatives in recent years. The annual Healthy Moms, Healthy Babies investment is now over $100 million, ongoing funding for initiatives implemented since 2021. In a minute, Dawn will discuss the challenges Michigan faces in terms of infant mortality and disparities. While all of us would like to see immediate results, the reality is true success takes long-term investments and commitment. The department's commitment to Healthy Moms, Healthy Babies is demonstrated again this year with the fiscal year 2025 budget recommendation. At this time, I'll go ahead and turn it over to Dawn to walk through the specifics of the initiative and what's included in the budget.
Good morning, everyone, and thank you for the opportunity to discuss maternal and infant health. As Amy said, I'm Dawn Shanafelt, the Director of the Division of Maternal and Infant Health, and also Michigan's Title V Maternal Child Health Block Grant Director. We will be sharing investment updates as well as 2025 proposed investments. MDHHS provides services and administers programs to improve health, safety, and the prosperity of the residents of the state of Michigan. As we share 2024 investment updates, please know that these are not all inclusive of the maternal and infant health strides that are being made as a result of the ongoing commitment and investment of the state of Michigan. Close to 45,000 postpartum moms now have 12 months of continuous Medicaid coverage during this critical postpartum period. 12,768 individuals have received reproductive health services under the Plan First benefit launched in July of last year. The Healthy Moms, Healthy Babies initiative resulted in a maternal infant health program pilot And the Maternal Infant Health Program, or MIHP as we call it, is the state's largest statewide evidence-based home visiting program. This pilot produced amazing results thanks to the partnership of the registered nurses and licensed social workers at MIHP agencies throughout our state. Enhanced visits were provided that resulted in families being 44% less likely to report cutting meals due to cost, 16% less likely to report going without essential utilities, and 36% less likely to report being unemployed, as well as an increase in satisfaction for the program of the participants. These are real changes that have directly helped our neighbors. Michigan boasts an impressive statewide perinatal quality collaborative that is made up of 9 regional collaboratives. Our collaborative structure has 3 charges: improving maternal, infant, and family health outcomes, listening and responding to families and communities, and making data-informed decisions. In 2024, the Regional Perinatal Quality Collaboratives issued $5 million in funding directly to community-based programs and organizations serving families to advance healthy births. Funds have been awarded for a variety of things, including breastfeeding, safe sleep education, including supplies that families need, such as pack and plays, addressing perinatal substance use disorder, preventing teen pregnancy, and linking families to supportive services during the pregnant and postpartum periods. Next, I'll pivot to doulas. A doula is a trained birth professional who helps families have safe, healthy, and positive birth outcomes or birth experiences. Doulas provide non-clinical, emotional, physical, and informational support to pregnant individuals and their families before, during, and after birth. Doula services have been shown to positively impact the social determinants of health, support birth equity, and decrease existing health and racial disparities. Michigan Medicaid began reimbursing for doulas in February of 2023 as part of the Michigan Doula Initiative. To date, there are currently 312 doulas on the registry and 192 that are now Medicaid providers. And the photo that you see on the slide here is a photo of an MDHHS-funded doula training class. There are Medicaid-enrolled doulas in every Michigan Prosperity region. In October of 2023, we released, one moment. This is a screenshot of the Michigan Doula Registry. Families and providers can now find doulas with an easy county search. This is an important step, and a really big step, in assuring that every pregnant person has the ability to have a doula as part of their care team if they so wish. This is another great picture, and it's another doula training graduating class that was funded by the Michigan Doula Initiative. In October of 2023, we released our latest plan titled Advancing Healthy Births. The strategic vision remained the same: 0 preventable deaths and 0 health disparities. This is a long-term effort, and I'm going to repeat that because I get asked this a lot. It's a long-term effort, and one that is being done under the direct guidance of families and communities. The priority areas are rooted in equity and our health across the reproductive lifespan, full-term healthy weight babies, infant safely sleeping, and mental, behavioral health and well-being. As we transition into the 2025 proposed investments, it's important to center us all with the why. The why is Michigan families. The infant mortality rate is the death of an infant before reaching their first birthday. In Michigan, our overall infant mortality rate has thankfully been slowly declining, with 2 recent years warranting celebration. In 2019, we hit a lowest on record for our state. And in 2021, we did it again with another lowest on record. Infant mortality rates fluctuate from year to year, but we are moving in the right direction overall. This slide delves further and clearly shows the challenge that Michigan and our country are up against. There are disparities or differences in infant mortality rates based on maternal race and ethnicity. We should have one unified Michigan rate, not differing rates for differing populations. Every family in Michigan has the right to optimal health. Every year in our state, there are an average of 90 maternal deaths. A maternal death is the death of a person during pregnancy and up to 1 year postpartum or post-pregnancy. The Michigan Maternal Mortality Review Committee reviews all of the deaths. And for the years 2016 through 2020, there were 442 maternal deaths, 106 that were pregnancy-related, with the most common causes of death being infection, blood clot, and substance use disorder. 305 of the 442 deaths were not directly related to pregnancy, but occurred while the individual was pregnant or within 1 year post-pregnancy. The most common cause of these types of deaths are accidental poisoning, drug overdose, and medical causes that weren't directly related to or aggravated by the pregnancy. Disparities exist by race, age, and educational level. Now, here's the call to action and the area of hope. 74.5% of the pregnancy-related deaths and 81.2% of the pregnancy-associated deaths were determined preventable by the Michigan Maternal Mortality Review Committee. Per the CDC, severe maternal morbidity includes unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health. Severe maternal morbidities have also been coined near misses. Examples of severe maternal morbidity include, but aren't limited to, the following: aneurysm, heart attack, eclampsia, hysterectomy, sickle cell disease and crises, and the need for mechanical ventilation. The severe maternal morbidity rates began climbing in 2018. As a result of persistent and maternal and infant health challenges, the Whitmer administration launched Healthy Moms, Healthy Babies in the fall of 2021. As you can see on this map, some of the counties with the highest, severest maternal morbidity rates, and as a reminder, that's the near misses, not deaths, but morbidity. These counties include Houghton, Marquette, Iron, Dickinson, Menominee, Benzie, Clare, Isabella, Saginaw, Tuscola, Clinton, Ingham, and Wayne. Counties shown in gray have numbers too small to report, thankfully. But this is a clear indication that this is a Michigan problem, and it's not isolated to a small area in our state. It's important to mention that the rates are based on the county of residence of the patient and not the hospital locations. The investments in birth hospital quality collaboratives and efforts such as Michigan AIM or the Michigan Alliance for Innovation on Maternal Health are making strides in hypertension, hemorrhage, sepsis, and infection. They're making strides in improving outcomes and decreasing maternal morbidity and mortality. And now we'll transition to the Healthy Moms, Healthy Babies proposed investments for 2024. Earlier, the successes of the Maternal Infant Health Program pilot were shared. There are 68 MIHP agencies with 98 sites across our state. The agencies are local health departments, federally qualified health centers, hospital systems, and independent or private agencies. The 2025 proposed investment is $3.2 million, with $918,700 of that from general fund to move from a proven pilot. So the pilot was proven, and now we want to move it to a statewide enhanced MIHP care management services model. MIHP serves more than 15,000 Medicaid-eligible pregnant individuals and 20,000 infants annually in our state. It's the largest evidence-based home visiting program in our state. The reach and life-changing effects of this investment will be substantial. The benefits of doula care were also highlighted a few minutes ago. The 2025 proposed investment would increase the Medicaid reimbursement rate to doulas for longer delivery. Deliveries can span several days, and ample compensation for this is needed. The investment will also double the number of reimbursable doula visits from 6 to 12. This is extremely important because it will permit reimbursement for visits when doulas are providing important things such as breastfeeding support and supporting their clients overall during that crucial period following the birth of a baby. In addition, funds are proposed to increase the number of trainings to train new doulas, resulting in increased access to doulas. And finally, supporting continuing education for doulas and a doula connection effort to link pregnant families to doulas. The 2025 proposed investment also includes further steps to increase access to centering pregnancy, an evidence-based group prenatal care model proven to positively impact birth outcomes and address disparity, as well as continued investment in the regional perinatal quality collaboratives and their local community efforts to improve maternal and infant health, as was discussed earlier. Access to reproductive health services is critical. $14.2 million in one-time general fund is proposed to increase access to local health departments and agencies to assist individuals and families in planning and spacing births, preventing unintended pregnancy, and preventive health screens. Our current family planning network is comprised of 91 clinics, and we fund a total of 33 entities. In 2023, over 45,000 clients received services. Access to reproductive health care improves birth outcomes. And now we're happy to take any questions.
Thank you for your presentation. I'll start it off with a question first. I thought the graphs pertaining to infant mortality and then maternal morbidity were very, very helpful to understand that as a problem, even though we are making progress when it comes to bringing those infant mortality numbers down. Where do we rank nationally in terms of this issue? Do we have any data on that?
We do, and I can share the specifics later, but in general, we are one of the states that isn't doing the best in the country. We're definitely not the worst, but we're not making huge strides given our disparate health outcomes.
Okay. Thank you for that. Rep. O'Neill?
Thank you, Mr. Chair. Thank you, staff, for your presentation and this information in terms of just the alarming statistics that consistently impact black and brown moms. You know, I have a personal experience. I have 3 daughters, and my middle daughter flatlined twice during birth. And the story is she told the doctors and the nurses around her that something's wrong.
Right.
This wasn't her first delivery. Outside of that, I could have lost my daughter. Okay, so this has been a main problem, Saginaw, as you noted.
And I'm from Saginaw, yeah, but
Okay.
you know, yeah.
Okay, and so, you know, I don't want to be a broken record, but you know, we know these issues, and systemically, we have to address those systemic levels of negligence, I would say, or ignorance of a young black woman saying something's wrong.
Right.
Okay, but to my main question. Community mental, the CMS system recently launched a new initiative called Transforming Maternal Health. And its model is it's allowed up. Kind of, when I shouldn't have got personal, so
I'm sorry.
it goes back to memories. But so this Transforming Mental Health model that will allow up to 15 states to receive up to $17 million for a 10-year period to improve health outcomes for mothers and babies. So my questions are, do you have any additional details on this initiative first? And then do you think Michigan will apply?
So I can say that our Medicaid team is reviewing the opportunity, and they are actually here. I don't know if
Yeah, we do have our Medicaid team here if you'd like us to have them come up to the table to speak to it, or we can follow up with additional information, whatever.
Good morning. I'm Megan Groen, the Medicaid director, for those of you who I don't know.
Hit your red button so we can hear you. Is it on?
Can you hear me?
Okay.
Okay, sorry. I'll sit a little bit closer. So I am familiar with the opportunity that you have raised, and it is something that our team is looking into. There's a couple different opportunities that CMS has put on the table that we are excited to review, and we need to take a look and see, operationally how that looks in Michigan and what that would look like. But it's definitely something that we are reviewing, and we would be happy to keep you updated on that as we kind of review those processes and see what that would look like in Michigan.
That would be helpful.
Okay.
A frequent update, not a distant update, as we go through this budget process. I would anticipate, Mr. Chair, if we could, receive some information in terms of, your action.
Absolutely.
As this problem doesn't go away, it just gets worse.
Yeah.
Right. So, thank you, Mr. Chair.
Thank you. Representative Steele?
Thank you for your presentation. Just a real quick question on slide 7 and 8. It looks like the total investment is $29.9 million. I just want to verify that. And I just wanted to know if any of these costs were reimbursed by the federal government, because I know that they reimburse for a lot of expenses.
Just want to clarify the question. Did you say on slide 7? Or were we
Oh,
looking
I'm
at
sorry.
14?
It's page 7. I'm sorry. It's It's slide 14 and 15, page 7 and 8.
Okay. Yeah, so on slide 14, the ongoing funding, it will be 5.3 million, and then there's additional 10.4 of one-time funding. So that, those two amounts can be added together. And then in addition, the 14.2 is for family planning services. So between those, it's approximately 30 million between all of the funding.
It is
requests.
30, okay. And then are they reimbursable from the federal government at all?
There are portions that are federal funded included in these amounts as well. Some of the rates for the doulas and things like that are included as far as federal reimbursable.
I just want to clarify, so 30 million would be the state's portion, and then the federal portion is separate from that? Or is
The
it
30 million is the whole component of it, and
then
then
the
there's federal within that piece.
like how much? Do you have any idea?
I believe it's about 10. We can verify and get that for you.
Okay, thank you.
Representative Hood.
Thank you, Chair. A couple of questions. How are we measuring whether current fiscal year investments and proposed fiscal year 25 investments are moving the needle in terms of birth outcomes in the state? And then second, I'd like to touch on the connection between drug use and overdose deaths that have soared significantly among pregnant and postpartum people. What investments is the state making to expand treatment services for this population? And how do we ensure safe care for affected infants in those circumstances? I believe it was Wyoming, it might have been Montana, that used opioid settlement dollars to support maternal health outcomes, because we often see that mothers who are on opiates after perhaps having a surgery to deliver are on a pathway to addiction and undersupported. So if you could sort of cover those things, I'd be thankful. Thank you.
I can start by, as far as birth outcomes and how we're measuring the current investments from fiscal 21 through now. They're measured in a variety of ways. So one concrete example, I mentioned the Michigan Alliance for Innovation on Maternal Health, or MyAIM. Those are our hospital QI efforts with birthing hospitals throughout the state. We measure and monitor things such as hypertension and hemorrhage, which are improving as a result of the AIM dollar investments for the birthing hospitals and efforts. And those are in line with the maternal morbidities that you saw, how it was going up until 2018, and then Healthy Moms, Healthy Babies was initiated in 2021. So we are seeing improvements as far as standards of hospital care, which Rep. O'Neill get to issues of bias and varying care, not listening to patients. When you have the highest standard of care and you're employing evidence-based practices and responses to every single patient with the patient's individuality, but in the same manner, right? You have the highest level of care for all patients. You see improved outcomes. So that's one concrete example. Another example, and there's many, but another would be the MIHP Maternal Infant Health Program pilot, and I shared the improvements in areas such as social determinants of health. The investment regarding that pilot was helping real families in real time on the ground. They had improved outcomes, and which is why the proposal is to scale it up statewide. It moves the needle for families immediately when they're being seen. And then the third one, doulas, and there are strides being made day to day. We started out in our state with 0 doulas on our registry, and now there's over 300. And when you can have a doula as part of your care team to be an advocate, to provide support, you're going into birth with a team, right? You have your family team and your friends and supporters, but you also, if you have a doula there with you who's educated on childbirth and postpartum care, that kind of shifts the power dynamic a bit, which improves outcomes. The next thing you mentioned, perinatal substance use disorder, and I'll just speak briefly to that. I won't get in specifically to the opioid piece at this point. I'll defer to others regarding that. But for example, you saw the soaring numbers or my discussion about overdose deaths, whether they're accidental, whether they're intentional. Resuming substance use whether it's cigarettes, whether it's Diet Coke, whether it's whatever a person was utilizing prior to pregnancy or at the beginning of pregnancy. Pregnant and postpartum people or pregnant people make the concerted effort most of the time to do what's best for their baby. They want to have a healthy baby. But anyone who's had a baby or been around a baby knows that after that child's born, it's a really challenging time, and recovery relapse can happen during that time. So that's part of the challenge that we're faced. So not only, as you said, the substance use or pain medications given as a result of C-section or something along that lines, which I think Michigan's doing a really great job in curbing that from happening. But we need to support people during the postpartum period. The focus is on the pregnant mom while she's pregnant, and then once she has the baby, the focus switches to the baby. And oftentimes we forget about mom, and that's a really critical, important time. You can't forget about mom. It's a dangerous time after they have their babies. So an example of something that is happening that's being funded with opioid settlement dollars is something called rooming in, and that's where babies who have been born and they're diagnosed with neonatal abstinence syndrome or substance exposure, hospitals are, if it's safe, always if it's safe, are having the babies room in with their families and do something called eat, sleep, and console, which essentially is let the babies eat when they want to eat, let them sleep when they want to sleep, console them, let bonding happen, have a quiet room with low stimulation, or stimulation, I made my own word, low stimulation. But what that does is it decreases length of stay in the hospital, it decreases the use for pharmacological treatment, so you're less likely to give a baby morphine or phenobarb or something like that, and it's a better experience for the family as far as stigma and bias. The babies aren't put in a corner in a NICU and labeled as, the substance exposed babies. So that's one thing that's happening in a variety of hospitals throughout our state. The Munson Healthcare System has it throughout, Hurley, Covenant Healthcare, and then there's numerous other ones that are coming on board. The hospital in Escanaba, and I'm sorry, I'm losing the name of it. OSF St. Francis, I think, is one of our newest hospitals. So that's an example of something that's being done.
Rep. Meerman.
Thank you, Chair. I'm wondering about going back to slide 12, severe maternal morbidity, basically the UP. What would you say are some of the biggest contributing factors to make that area stand out as it does?
I think some of the biggest contributing factors are the fact that in the Upper Peninsula, or in our rural areas, those are areas of isolation. And when individuals are isolated, you have increased depression rates, you have increased smoking use, because that's oftentimes a self-medication, and then you have increased obesity. I mean, just in our state in general, right? When we have, maybe not this winter, but many winters, when you don't have the ability to go out and move around because of snow, that increases that and prompts chronic health conditions, right, such as diabetes and high blood pressure and things of that nature, which puts someone at more risk for maternal morbidity.
You think that area, if it's okay, a couple follow-up questions. You think that area stands out because there is sort of a lack of data generally in the UP? Because, I don't see that as any more rural than, some of the other areas that seem to be doing a lot better. I don't know if it has anything to do with the state line, if people need to go across the state line to receive health care. I mean, we have, a hospital in Iron Mountain there, but it's just way out of line with anything else that's going on in Michigan from morbidity.
Right. I can delve into that further with our maternal child health epidemiologists. I can tell you offhand, though, that I think that probably mirrors smoking, obesity, diabetes, asthma rates. But we'll delve further into the Upper Peninsula and get you some more information.
And then the last thing is, I appreciate that, kind of to-dos,
Mm-hmm.
How do we attack the area that seems to be in the worst shape? So that's what I would encourage. Thanks.
Absolutely.
The committee will go at ease.
The committee will come to order. Thank you, Vice Chair Martis, for taking over for me for a few moments. We have a couple more questions for this panel. Rep. Braybeck?
Thanks, Chair. I appreciate it. Thank you all for being here. I'm wondering, we've alluded to 2021 kind of being a demarcation in terms of when, particularly when we had Healthy Moms, Healthy Babies instituted. And we can see the data and also see the goal of 0 preventable deaths and 0 health disparities. Sorry, I don't have my glasses on. And I guess I'm wondering how long it's going to take before we see substantive change and what your hypothesis is on that. Trying to get an idea of expectation setting here.
Well, we can see that on the slide that I showed that infant mortality rate is slowly going down. The disparity ratio is not going
Right.
down. And that's the rates are going down over time. The Black maternal health outcome rates and infant mortality rates, if you look at where we're at now compared to where we were in the the 2000s, early 2000s or 90s, 80s, 70s, we're improving, but it's a real slow trajectory, which is why an accelerated effort was needed, commitment with long-term resources to turn this around. That's the only way that, and a focus on systems level. So as far as when we'll see things, we're on a slower trajectory, but I think it's important to point out that when we measure things such as maternal mortality and infant mortality, pregnancy is 10 months, 40 weeks, and then we measure up to 1 year postpartum. So you're already talking 2 years. And so that's why you need to wait to see what happens to hopefully the mom has a successful pregnancy or a healthy pregnancy and babies celebrate their first birthday. That takes 2 years to know that. So I think that's part of the reason why. And then we also, at this point, we're moving slowly down. And I'll have the EPIs weigh in and share a bit more information as far as what the projections are. We do have projections.
That would be super helpful. And Chair, I have a follow-up, if I may. I just wanted to lift up what Rep. O'Neill said. It feels like because this is slow going, and I know when I look at these numbers, I want it to go faster because
So do
they're atrocious.
Right.
And when we have opportunities like we do from the federal government to get this waiver for social determinants of health, to me, it seems like a no-brainer to do something like that, to be able to bring these funds to support folks here in Michigan to this. And so I would also ask, for an update on that, because I know that that's been an option for us for now several months. So thank you. Thank you, Chair.
Rep. Farhat?
Thank you, Chair. I noticed the data in the chart. So first I want to go back to a point you made. When I look at 2022, is that the mortality rate of 22 from births of that year, or is that from the previous year? Because you said when you track the data, birth is 10 months, and then it's a 1 year follow-up. So just when I look at a year, right, is that the preceding year's kind of infant mortality rate? Like, how do I desegregate the data when I look at it?
Right. That's the birth year of the baby.
Okay.
That's their date of birth.
And so do we know when we can get data for 23? Do you know how long when that'll be available for us?
So for data for 23 means that we would go up to when babies, the last baby that's born on December 31st of 2023, and then you go out 1 year, which would be December 31st of 2024. And then there's usually a bit of time that's taken because sometimes Michigan babies are born outside of the state of Michigan. Sometimes there's babies born in Michigan that aren't Michigan babies. So there's a bit of data cleaning that has to happen in order for that to happen. But it's typically about an 18-month lag.
I guess, and that's a good point too. But I guess my biggest question is I look at I'm looking at this map or this chart from 2013 to 2022, right? It is a slow decline, yes. But when we look at it from a kind of a 10-year, let's call it 10 years, it's 9 years, right? Black non-Hispanic infant mortality rate is at 12.5. It's at 13.3 now. Right, and the only, I would say, kind of significant divot was in 2018 to 2019 when it went from 14.5 to 12.5. Is there a particular intervention in that kind of time frame that was, extremely successful? I mean, can you help me explain what happened in that chart that led to, such a pretty big decline in 1 year?
A decrease in sleep-related deaths
Got it.
led to that improvement.
So there wasn't a particular intervention or anything?
Well, there's a variety of interventions. So education as far as safe sleep, but then going beyond that, right? There's one thing to know about safely sleeping your infant. It's another thing to address the social determinants of health.
Sure.
So you need to have a warm house, a safe house, a place for your baby to safely sleep. There's a whole lot that goes into that beyond just the pack and play.
So then the subsequent kind of 19 to 20 jump when it went back up, right? That safe sleeping kind of intervention helped in that 1 year or whatever interventions. I mean, what I'm trying to get at it here is, I guess, truly, I mean, this is the one that breaks my heart the most on this committee. Every time we have this presentation, it breaks my heart, right? I'm not a father yet. I look forward to the day I can have kids, and it is one of the hardest things, I think, for a woman to do is deliver a child, right? But it breaks my heart when I see that it's nearly 3 times. It just breaks my heart, right? And so my question is, how can we? I mean, it's my commitment. I think everyone here is committed to it. What is, and there's no silver bullet, but how can we really get this down more drastically, right? Instead of the 0.1, 0.2 decline that we're seeing, maybe how can we see these big chunks taken away at faster?
I think it's a multi-pronged approach, which I've said before. As you said, there's not one silver bullet. If there was, it would have been done. And then also understanding that there's external variables within systems that make people sick. So just as extremely disheartening, and I've said this before, I've been doing this for 30 years in this area with infant mortality. We have successes, but it's not coming down. Whenever you have preventable deaths in moms and babies, that we're definitely not done yet. And when you see these disparate outcomes, but you see the same or similar disparate outcomes in asthma, in cancer, in a host of other areas, that tells us that we have systems level problems that are making people sick. And so to change systems, that takes time and it takes investment in resources and human capital. That's not something that could be turned around quickly. I wish it could.
I want to be clear. I think you folks are doing fabulous work. We're partners here, and this is one that breaks my heart every time we get this presentation.
Mine as well.
So I appreciate your work on this.
Thank you.
Rep. O'Neill.
Thank you, Madam Chair. And just to follow up, a couple quick questions. First, does Michigan Medicaid program reimburse licensed midwives and certified nurse midwives for care? The second one, does Medicaid reimburse for maternity care provided in a community setting, not in a hospital, nor in a birth center?
Excuse me, thank you. Amy. In terms of certified midwives, yes, we do have reimbursement for midwives. In terms of birthing centers, to my knowledge, birthing centers are not licensed in the state of Michigan. And so Medicaid does not reimburse in unlicensed facilities like that.
Thank you, Madam Chair.
Rep. O'Neill, it's my understanding that a statutory change is required to allow for that, and there is a package working through the House and Senate to address that. All right, we're going to move on so we can fit everyone else in. Thank you so much to the panel. We appreciate you. Next, I'm going to call up Amy Zagman, Executive Director for the Michigan Council for Maternal and Child Health.
In the interest of time, I will start. Good morning, everyone. I am Amy Zagman, Executive Director, Michigan Council for Maternal and Child Health, and really appreciate the time today. My presentation you have in a packet, along with a number of other handouts that I thought might be helpful for our conversation. In the interest of not singing the same song in a different tune, I will sort of breeze through a number of these slides that have been covered largely by the department's presentation, and really try to bring to you the perspective of the council's membership, which you have listed. We are made up of a number of organizational members, and really pride ourselves not only of bringing the voice of those individuals who are primarily involved in the provision of medical care and services to across the maternal and child health spectrum, but we also really are at the table at a number of other places where policy is discussed. So believe it or not, small but mighty, we try to cover as many of these advisory committees and other places where very specific portions of maternal and child health discussions are happening, everything from the medical care advisory, the Medicaid advisory, to the perinatal oral health advisory, so where we talk about the oral health care during the perinatal period. We're in those conversations, we're listening for what policies are standing in the way of making progress to improve maternal and infant outcomes, maternal and child health outcomes. And so in that vein, I'm hoping to bring you the perspective of many voices today with regard to this conversation. Just one note, too, I've included our policy agenda. As the name implies, we're the Council for Maternal and Child Health, and I love to talk about maternal and infant health. But if you ever want to talk about things that stretch into adolescence, we're also very concerned about all of children's health and are here as a resource. And so please, I'm here in Lansing. If we've not had the chance to work closely together, which some of us have, please let me know, and I'm happy to call on my membership for their expertise. We've already talked a little bit this morning about the why. I brought you some graphs and charts that may be complementary to those that you've received from the department. Complementary, probably not the right word, given that the news in a lot of these charts is not good. So you've already seen the infant mortality rate, the disparity that's represented in those rates. And I wanted to highlight just for a moment, if I could, the maternal mortality rate, which in Michigan is really the data that we have comes from a maternal mortality surveillance committee. We have one of the most robust surveillance committees in the country, and they do an amazing job. I pulled just a few excerpts from their work that really delves into sort of the why, which we can't get to the how or the how we can fix it if we don't really understand the why. And maternal mortality is separated into pregnancy-related and pregnancy-associated, which Dawn spoke to. But I pulled for you just the preventability statistics and also the causes, which she also mentioned. So again, I'm not going to get into those, but I just wanted to point out to you that I pulled just a small portion of what's available in the report. If you're interested in reading the report, I think it has a lot of information that might be useful as we continue these really important conversations. I did also obviously have a slide about severe maternal morbidity. We can learn so much, as Dawn said, from those near misses. Those are, they represent a much larger number, thankfully, than the actual deaths. And they represent huge opportunities for us to make changes going forward. We are working in a time when you all have expressed an amazing amount of interest. That's happening nationally as well. And so there are, as we've talked about this morning, national resources, state resources. I would say the ongoing commitment from the previous administration that's been amped up by this administration. There's been appropriations. And there's been a real focus on listening to community voices, which I think is so important, because when you delve into the data, what you see is that there are, we've mapped this in so many different ways, and we look at different maps. There are different underlying causes in different parts of our state. And so we really need to empower all of the folks working in the perinatal period locally to come up with, solutions and targeted investments in their area. And so that collaboration is happening. But I would also just echo, and again, don't want to just sing the same song, but we have to maintain these investments over time. We really need to invest in things like, and continue the investment in the Michigan Alliance for Innovation in Maternal Health and the Regional Perinatal Quality Collaboratives. I brought you a handout that shows your Regional Perinatal Quality Collaborative, the contact person for your collaborative. I would strongly encourage you to reach out. That's the place where you can really find out your local data and find out what's happening locally. What are the projects that they are funding with that state, the funding in the current year budget that we hope is continued in FY25. But what are they doing? What are they really doing locally? And how can you help support that? I am going to skip ahead. Obviously, we want to talk about FY25, but I did obviously bring you some information about the perinatal quality collaboratives, and just wanted to mention that we also have other information in the packet as well. So with regard to the FY25, 24-25 executive recommendations, we support the recommendations. Probably not a surprise. It finds that many of these things echo what we also hear from the field, that investing in things like home visiting, particularly a rate increase for the maternal infant health program, which is long overdue, and making sure that the doula initiative that's been started over the last couple of years is responsive to what we're hearing from the doulas and hearing from other providers to make sure that those services are really available and sustainable. These investments that have been proposed by the executive really echo what we've heard. One thing I will say is, just as we've talked about sustaining and really staying the course, we've got to quit one-time investments. They really don't work in medical care. They might work for grants, they might work for projects, and in that way, there's certainly a place. I will say what it doesn't work for is adding service delivery. So, providers are not naive to the state budget. Obviously, it fluctuates. And they don't want to start projects. They don't want to go out and find staff. It's hard work to start a program. It's hard work to find staff, to hire staff, to put them through training. So things like centering pregnancy do not lend themselves to one-time investments. If I'm an OB clinic and I want to start a centering pregnancy group-based prenatal program, that's a significant investment on my part. I have to find a space for the group to meet, which may not be something that naturally lends itself to my physical office. So I am making a commitment to a model that we know has benefit and works. I brought you information about the current centering sites in Michigan, as well as some information from the National Center for Healthcare Institute. But we need to really think about, and I know you all are here for only a certain amount of time, but really need to think about if you're going to make these commitments, they need to be made over multiple years so that providers know that if they make these investments that they'll stick. And so I think the proposal around centering pregnancy, one way that we can think about sustainability is on the back of the sheet from Centering Healthcare Institute, and we really could think about Medicaid reimbursement. And I know this has been an ongoing conversation, but I would encourage the state to pursue it further and for you to encourage them to pursue it further. But a number of states, 5 of which are listed on this handout, have figured out how to, for Medicaid recipients at least who are involved in centering pregnancy, how to capitalize on Medicaid reimbursement, which obviously creates a sustainability structure that helps those practices. The other piece would really be to think about whether there's an opportunity statutorily to make sure that centering pregnancy and group-based prenatal care is available to all those who might voluntarily want to engage in it. So making sure that all insurances, whether they choose to or whether you tell them to, are reimbursing for centering pregnancy, because that really starts to create a sustainable structure where if a provider knows that for every pregnant individual who is enrolled in centering, they can count on the enhanced reimbursement, then they can really, they know that they can make that commitment. And so I think there's an opportunity there with centering. We know that group-based prenatal care has better outcomes. I don't know if we have time for a whole centering presentation today. I would encourage you, if you're interested in that, I gave you the sites. One of them may be located in your district. I definitely would encourage you to pursue that with them because we know that they have better outcomes. And much of the cost benefit of those better outcomes is going to accrue to the insurer. That's why we see insurers interested in funding centering pregnancy. The other point that I would make is you heard a number of things that are coming specifically from the maternal and infant section of the department. Just knowing, and you in your questions got into this a little bit more, but there are many things that contribute to maternal and infant health outcomes. Some of them are things that the department focuses on, some of the things that the providers that I work with provide. Many of them are things about the context of our society, the structure. There are other offerings that are in the DHHS budget and in other budgets. So I just pointed out, I mean, we didn't talk at all about this yet today, but there's definitely things in the DHHS budget that I would tell you that our members would say have just as much impact on maternal and infant health outcomes. Definitely making sure that there's funding for vaccines for children, right? Making sure that children are properly vaccinated, making sure that pregnant individuals are properly vaccinated, have access to education and materials to make that choice about vaccination. And definitely behavioral health. One of the predominant things that we hear about is access to behavioral health. And I know you'll be probably delving into a behavioral health conversation, but keeping in mind that many of the underlying issues that we see are behavioral health related. We have just a couple, if it's okay, a couple of other things that the council would encourage you to think about as far as asks. One is also in the area of home visiting. You heard a little bit earlier, and I talked about the maternal infant health program, which is just one home visiting model. I think you're going to hear from another home visiting model today as well. There are a number of home visiting models. I brought you an excerpt from the state's home visiting report. I didn't bring you the whole report, but I brought you just enough so you can see the tremendous outcomes that home visiting programs, when we pair a trained professional with a family who welcomes that professional into their home voluntarily during pregnancy or in the early childhood phase, the tremendous outcomes that we see. And that can be various models and various programs. You may know it by different names in your community, but we know that that is a system that works. And so we don't always have to be looking for the new thing. Sometimes we can be investing in the thing that we already know works. So things like the MIHP rate increase. We also would ask that we revisit a line in the budget that is specifically for rural home visiting programs. And that line has not been increased in 10 years. So those programs that are being funded in high-risk rural communities, we think deserve a look. They are not eligible for some of the federal funding that comes for home visiting just because the numbers are not great enough, but we really need to go back and make sure that we're providing inflationary increases to programs that we know have had outcomes over the years. So definitely we would ask to revisit the rural line. We also would ask with regard to home visiting that we think about the fact that we have this robust system across 2 state departments, 6 agencies fund home visiting, and that requires a lot of coordination to make sure that those things work, to make sure that families are aware of all their choices in the community. There are a lot of efforts that are made across those 6 agencies to work together, but there's no one FTE, there's no one place in state government that is responsible to coordinate that activity. And so really thinking about would we get more efficiency if we had that sort of structure, a place where we could bring together funding from across those funding streams and do things like provide professional development to the field as a whole. And so that's certainly a space where when we're sitting at the home visiting table that we consistently sort of see there would be some benefit. I brought you, and we already talked a little bit about Safe Sleep, so I'm not going to delve into it, but another place of sort of ignored investment in the budget. We have a line in the state budget around safe sleep and suffocation prevention. It's been $321,300 since I started this job 15 years ago. So it's a very preventable cause of infant death, and just would ask that we think about the fact that if we're serious about preventing sleep-related deaths, that we need to reflect it in the state budget. The last thing I'll mention, and you have a copy of a brief that we published in 2021 around re-examining perinatal payment structures. And I was so happy to hear Representative O'Neill bring up the federal grant opportunity. Whether it's the federal grant opportunity or whether it's funding that you all might put in the budget to require the state to do a study, we've been asking for some time to re-examine the way in which we fund perinatal care in the state. We've done a great job adding things like doula coverage. We've added, extended postpartum coverage to 12 months in the Medicaid program. But sometimes I think maybe we should stop and ask ourselves, do we have disparate outcomes because we're getting what we're paying for? And would it make sense at some point to stop and say, should we look at the way in which we're paying for perinatal care in the state? And that's not just a Medicaid issue. So I'm very grateful that you brought up the opportunity. I think we would be very supportive of the state pursuing the opportunity to examine the Medicaid payment system. But it would also be incumbent to think about whether there are opportunities for the legislature to engage the entire payment structure, all of the payers in the system, to say, could we do this differently and get different outcomes? Are there different things that we could build into our perinatal payment structure from the get that would allow us to get different outcomes? Are we paying for the wrong things? So I know that you're on a tight timeline, and hopefully I didn't talk too fast.
No, I'm sorry. It was, you're under pressure. Thank you for that informative presentation. What I would like to know, and excuse me if I missed this because the question was asked while I was gone, considering, the really just unbelievable racial disparity aspect that we have here, which of the investments do you think most directly impact the racial aspect of maternal and infant death in this state? Do you have any thoughts?
I'm not going to say one, but I will say two. So I think, and Dawn mentioned this earlier about my aim. So the quality improvement effort at the hospitals, where we know that for the highest causes of maternal mortality and morbidity, that we're standardizing the response across hospitals, that this is an effort to make sure that the response is always the same for hemorrhage, for hypertension, for sepsis. I think that is a tremendous opportunity to remove biased treatment at that point. And then I do think that we can't get to this because Michigan is such a diverse state, and I mean that in every way possible. We can't get to this problem if we don't really look at local data and have local partners working together. So those investments in the Perinatal Quality Collaborative, I think, have to continue. We have to be committed to our local partners and listen to what they say and make investments locally.
Okay, thank you for that. The other thing, we have so little time, but it is notable how many issues there are with substance use disorder. And there isn't, obviously the state is getting $1 billion over the next 17 years in opioid settlement dollars. And it seems like there should be a connection. We should be investing maybe on the pregnancy, specifically substance use disorder in pregnant women. I actually have a friend who's an ER doc, and she says, they see pregnant women that are in there and they're using, and they're just not even necessarily offered, medication-assisted treatment, or, they're not really supported with what they need. So, I mean, maybe it's not a question, but I mean, is there anything that you see, investments that we've made that directly address that aspect?
I'm probably not the best person to speak to. I think Dawn did mention earlier that there are some efforts between the behavioral health section of the department and behavioral health providers and maternal and infant providers. I think more needs to be done, to your point. I think just as I would say the same is true on the mental health side, that we do not have enough behavioral health providers who are willing to see or trained to see women in the perinatal period. The same is true with substance use, right? We are spread so thin with those providers, and they don't have the necessary expertise to really make sure that we're focused on that population. So it is a function of a lot of other problems that we have in healthcare.
Okay. Well, I'm sorry, colleagues. We have to move on because we have one more presenter and we have to be out of here at 11:45. So, Director Zagman, thank you so much. Feel free to follow up with her for any extra questions that you have. So finally, we're going to call up Julie Beam from the Kalamazoo Nurse Family Partnership. Welcome. You just need to make sure you turn on the mic button.
Good morning. Can you hear me okay? Okay. Good morning. Thank you, Chairman and Committee, for allowing me to speak on behalf of Kalamazoo Nurse Family Partnership today. I have been with, my name is Julie Beam. I am the supervisor of Nurse Family Partnership and have been for the last 9 years. It is a program that is near and dear to my heart. Kalamazoo Nurse Family Partnership enrolled their first client in 2008, and we've enrolled over 1,000 and graduated over 300 since that time. Nurse Family Partnership is a evidence-based home visiting program that has been in practice for nearly 40 years and is actively present throughout the country for the last 20 years. The first NFP in Michigan was in Berrien County, and that was over 20 years ago. Nurse Family Partnership partners a highly trained registered nurses with parents. And as when I'm talking to moms about becoming part of Nurse Family Partnership, our goal here is to truly be a partner with you. And what we can offer to each family looks different. You always have the benefit of an RN with assessment skills who can help you to, for one, identify problems within health problems, but also has knowledge of the healthcare system. So we can offer that ability to navigate some of the healthcare system issues we've heard talked about today. We're also there as advocates to help advocate for them, to help build advocacy skills within that family. We're there to support the families with education because we are there during the pregnancy. We enroll before 28 weeks of pregnancy, and we stay with them through pregnancy, infancy, and toddlerhood. So we're there until the mom is 2 years, or the child is 2 years of age. So education on how to have a healthy pregnancy, good nutrition, in helping people to navigate issues like substance use, perinatal mental health issues as they move into childhood. What does it look like? What does it look like to have a newborn? What are the things that you need to do to care for your newborn? How do you cope with a child who doesn't sleep at night or is struggling to feed? They always have access to that nurse to partner with them and walk them through those things and guide them when this issue is something that needs to be addressed by the healthcare system. On into how do you support your child to grow and develop and answer any questions they may have. Because we're a broad-based program, we also can help support the families in accessing resources within the community. We have, at times, can help the family prioritize where their money goes. We can help with budgeting. We can help remind them of the different systems that are placed to support them. We can help them locate quality daycare, return to work, all of those different things that can really change the trajectory of a woman's life over the time that we're with them over that 2 years. And that looks different for every mom. So I can't say that there's one path through with any of the families that we've been a part of in the time that I've been there. And we have had families that are hearing impaired, vision impaired, cognitive challenges, as well as the things you often hear about, which are families with substance use, domestic violence. Currently, I have a teen who enrolled with us when she was 14, was when she became pregnant. And we have 2 moms who were trafficked by their family as adolescents. So we come across a large variety of different situations and requires a little bit of navigation each time. And I'm certain this happens with every home visiting program that is funded. I can only speak to mine. And I don't have a lot of data here for you, but I do have some personal experiences related to the families that we've served. The first one I'll share with you is a client that I had when I first started with Nurse Family Partnership. She's very near and dear to my heart because I had known her from the pediatrician I worked with prior to this. And so when I enrolled with her, I already knew her. She had some cognitive delays. And at the end of our 2 years together, I felt a little defeated, like I really hadn't gotten as far with her as I had hoped to over the time. Yet she kept in touch with me over the years, and it speaks to what they talk about is this is not a short-term intervention. About once a year around her daughter's birthday, she gets in touch with me. And at the time her daughter had started school, when we talked, one of the things we had talked about is family planning and being ready and prepared to parent another child. And it took me a bit to get that message through to her, but it finally took root. And the two things she shared with me that she had continued to do that really benefited her was, she had not had an additional child, so she had the resources personally and financially for the one. But then she also read to her daughter every day. And for me, that's a huge win because we all know the benefits of reading. And so that's 7 years from when I, first contacted her. That was still part of her being. And so sometimes those rewards take a while to get to that. And one of the things we like to ask parents when they graduate from our program at 2 years of age, with their child's 2, is to share their story with us. And I won't say a lot of them do, but some of them do. And I'd like to share just a couple of those with you. One of them is a young woman, and her story is that she was adopted at 7 years old from an abusive situation. Where she moved a lot after her biological parents were back in the picture. Moved out of state at 16, came back at 20, was making some not so great choices. Drinking became an issue. She went to rehab. She met her son's father, and she's got in parentheses, I know, and stayed sober, but the father of the child didn't. So she eventually became a single mother when her child was an infant. And she said her nurses had been my legs when I couldn't stand emotionally, a listening ear when I needed to vent, and the mother figures I needed when I had questions about how to do anything from dealing with a sick baby to finding myself a doctor. And then another one said, my nurse came to me when I was pregnant with my first child. At the time of my pregnancy, my pregnancy was very stressful as my husband was fighting a case and was away from home, and my stepson was a handful as well. I really appreciated the times that I shared with my nurse because it gave me some time to reflect. It was nice having someone who was just there to listen and also give me advice and knowledge about what was happening to my body. I was excited to find out what I should be looking for with my child's growth, and excited to praise her when she met them. It was also really fun to do the activities my nurse brought. I also liked that I could talk with my nurse about the doctor's visits and get a second opinion about any issues or concerns I had. And I think that every first mom should have someone like my nurse for her first baby. That's all I have to offer you now. What questions may I answer for you?
Well, thank you, Julie, for providing that testimony. Rep. Steele has a question.
Just a real quick one, and it actually goes to all the different programs, so I appreciate your testimony. And I'm just wondering how much that we you know, like how it takes a village to raise a child. How much of this do we go out into like the community with like other portions of the family, churches, community centers, to do more of a collaborative effect, because it takes a lot, especially for like the single mothers and stuff. And I'm hoping that we engage in all that, because I think that would help with the education as well moving forward.
I agree with you, and that is something that that we definitely do is connect them with local resources, connect them with, we often will take them for visits like at the public library for the story hour, or connect them with local groups in town where they can connect with other mothers. And something I almost forgot to mention is we were funded this past year to include an outreach worker. And that is going to be, her focus is helping us to connect with moms that we sometimes have more trouble connecting with, ones who have less trust with the system. And the beautiful part about this is she was one of our NFP moms. So she's been through the program, she understands it, and she also became one of our parent leaders. And within her being part of our program as a parent leader, I saw this wonderful gift she had for connecting with people and engaging, and all of the people she was involved with. And so when I had the opportunity to bring in an outreach person, she was my first thought. And already in the 6 weeks she's been with us, or actually it's more than that, 2 months now, she has connected with so many people, and is brings such energy and joy and a different perspective, because she's not a nurse. She's had a different life experience than many of the other team members that we have, and having her presence on our team has really helped to grow our knowledge and understanding of the community we serve.
Thank you, Julie, so much for that. Rep Hood had a question, but we're out of time because there's another committee coming in. So I apologize, but we can certainly connect you to Julie if you have a follow-up question. I'm sorry. Same Rep Boleyn. Sorry about that. This is a subject I'm sure we could spend hours and hours on. So thank you to everyone who was here today. Rep Farhat moves to excuse absent members. Seeing no objection, motion approved. Seeing no further business for the committee, we are adjourned.